physician. And what that means is I see about 20 to 25 patients a day. On a given year, that amounts up to about 6,000 patient encounters. 6,000 opportunities in which I can help somebody with chronic pain. That's a tremendous opportunity and honor that I keep sacred every day. Problem is, recently, what's been happening is I find myself having difficulty caring for and caring about my patients. This is Philip, my son. He's the most precious thing that I know. He's the most amazing person, and I care about him a lot. What I've been finding myself doing recently is I've been finding myself speaking to my patients less and less about Philip, who is very important to me. Now, you may say, well, that's normal. You know, there's a degree of professional relationship between yourself and your patient. You should keep your personal life separate. To some extent, that's very true. But I think if you really care about something, I'm one of those people who love to share about what I really care about. And what I am noticing myself doing recently is I am starting to, and this isn't just me, this is my colleagues in pain management and primary care. We're all starting to withdraw a little bit, making our relationship with our patients more of a business transaction. We're starting to see patients more as customers, and we're starting to see our encounters as an opportunity for business. And one of the reasons is this. This is a picture from Ohio. Don't worry, the patients are not dead. They're sleeping after a heroin overdose. And there's a child in the back seat. It's because pictures like these are becoming symbols of the opioid epidemic. When there's a clear difference between overprescription and prescription abuse and what I would call a heroin addiction. Now, there is a relationship, but images like these are becoming what everyone thinks about when they think about a patient who's on chronic opioids. And that is becoming a very challenging issue. We're starting to stereotype chronic pain patients on opioids with heroin addicts. Also, another stereotype. Pain physicians, primary care doctors who prescribe opioids are now starting to be stereotyped into pill mill doctors who basically prescribe pain medications, powerful drugs to anybody and everybody. And we receive quite a bit of criticism for that. You know, Dr. Mackey mentioned this letter that was sent by the Surgeon General to all physicians around the country, asking us, pleading with us to take the pledge. Take the pledge to reduce the amount of opioids that we prescribe. And he provides CDC guidelines, checklists, steps that we can do to improve our care. This is a great tool that we can use. But on the other hand, this is also becoming an excuse for primary care doctors and pain doctors like myself to be able to point to something and say, look at this. This is why I can't prescribe you the medication that may help you feel relief and be able to function better. We're starting to enter an era of medicine where we're allowing guidelines to make things easier for us and make us and help us take less risk and care less about our patients. You know, within a 15-minute visit with a patient, I have to try to balance the needs of patients, the needs of society, insurance companies, referring physicians, practice, and there's a whole long list of them. We're trying to balance all this, and what is becoming easier and clearer is that if I just follow the guideline and tell the patient, no, I can't prescribe this amount of medication for you, it makes my job a lot simpler. I felt that when I found this quote, I said, wow, this is really appropriate for this talk. Eleanor Roosevelt said, "We are afraid to care too much for fear that the other person doesn't care at all." This is what pain doctors, primary care doctors, everyone who prescribes opioids are going through right now. Why should I take the risk and prescribe this patient a large sum or even a moderate sum of opioids when no one seems to be caring for us? Patient doesn't care about my license or me going up to the board and explaining to myself if there's a potential overdose. Insurance companies don't care about me. The government is sending out guidelines that I should be doing something in a certain way. How do we fight this? I actually have a whole different set of slides after this, and actually I was telling my wife about the talk, and she said, why don't you talk about one of your patients instead? And she mentioned that because one of my patients passed away a couple of days ago, and I got a notification, I got a text from one of my referring doctors who was also taking care of her. We'll call her Mary. Mary was in her 70s. She had severe rheumatoid arthritis. She had back surgery ×3. She was on large doses of opioids. She was on prednisone for a long time, immune disease modifying medications. And her rheumatologist and surgeon basically said, there's nothing we can do. We've tried all the medications. Can you help her with opioids? I actually inherited Mary from a different pain doctor who'd been working with her. And she was on massive doses. Current CDC guidelines put the cutoff at 50 milligrams of morphine daily equivalent, 99 milligrams of morphine equivalent. If you have to, anything beyond that, you're playing a dangerous game. She was on close to 300 milligrams of morphine daily equivalents, a 70-something-year-old. And when I met her first, I think I may have been a little bit naive. I don't know. I talked to her. I remember the first time I met her. She's such an interesting character. She's a very hardcore Democrat. She's been going to conventions. She was a representative at one point. And first thing she asked me was, are you a Democrat or a Republican? Because if you say Republican, I'm walking out of here. Maybe I was naive, but I went through all the dangers of opioids and how their benefits are limited. She was on several times the recommended dose, and I said, we need to come down on these. And she was hesitant, a very nice lady. She said, but if you really need to do this, okay, let's try it. In the course of 2 months, we went down from almost 300 milligrams of morphine daily equivalent to about 70. She ended up in the emergency room twice. Why? She just couldn't take it. She ran out of medications early, about 4 times. We had a real long talk. This is after several months of knowing Mary. We sat down and said, look, you're coming in early, you're going to the emergency room. What's going on? And she said, I just can't do it. It hurts too much. Can we go back to the doses that I was on before? She cared. She cared enough to try what I recommended. And I felt like I owed her the chance. And so we went back to that insane amount of opioid. And, she continued on as the president of our condo association. And she likes to pass buttons of Hillary. That was her thing. And she did well. Now, may she rest in peace. But in the back of my mind, even right now, there is a piece of me that's concerned. What if she passed away because she was on high doses? What if she had pneumonia or something and she took a little too much? What if I was the cause of her demise? It's a very complex relationship. I don't have graphs to tell you that this is what the rate is. I have 6,000 opportunities every year, 20 to 25 a day, to meet each patient and decide what I think is the best thing for them. And I think there needs to be a real conversation about what is caring for our patients? What does it mean for us to care for patients and for patients to actually also care for us? Thank you.